Good afternoon, everyone. Thank you for coming. My name is Camille Crittenden. I'm Deputy Director of CITRIS and also direct the Data and Democracy Initiative and the Social Apps Lab here at CITRIS. We're really pleased to have you here with us in the audience today, and also want to welcome our web viewers who are joining us remotely. We have this live cast to the other CITRIS campuses at UC Merced, Davis, and Santa Cruz. And of course, it's also available anywhere you have access to a computer, and will be archived for later viewing if you want to go back and take a look. Just a couple of brief announcements before I introduce our afternoon speaker. Thursday, November 6th, that's just next week, 8:30 to 4 p.m. here will be a conference on enabling technologies for the next generation of the intelligent energy infrastructure, which is hosted by one of the CITRIS initiatives, I4Energy, along with Becky, the Berkeley Energy and Climate Institute, which is housed here at Sutardja Hall. So we hope you'll take a look at the program for that and join us all day on Thursday or for any portion of that day. One other announcement is on November 12th is the deadline for the Big Ideas at Berkeley contest. If you are aware of this, it's run through the Blum Center for Developing Economies, but CITRIS also sponsors a category for IT for social impact, IT for society. Also, the Data and Democracy Initiative, which is part of CITRIS, sponsors the Open Data category and the Conflict and Development category. So take a look at that if you have ideas about how you would like to implement or scale up a big idea. It's my pleasure to introduce our afternoon's speaker, Dr. Nick Anderson. Dr. Anderson is Director of Informatics Research at the UC Davis Health System, where he does research into the effective uses of biomedical data, information, and knowledge for scientific inquiry, problem solving, and decision making. Because informatics is at the core of many transformative efforts in healthcare, Anderson's expertise and leadership will help build the institution's capacity to optimize information technology and further develop this important field throughout the organization. We're very pleased here at CITRIS to be able to work with Dr. Anderson and his colleagues at the UC Davis Medical Center, and we're very happy to have him here to share some of his insights with us this afternoon. Please join me in welcoming Dr. Nick Anderson.
Thank you. Hi there. Pleasure to be here in Berkeley where the beautiful people live. This is a little not traditional towards some of the presentations I have, which is on specific projects, because I thought that this is an ideal opportunity to spread the gospel of pragmatic translational informatics. Despite the title, it being for health, this is predominantly for research and the support of health. So I think I'll start with what that means. So pragmatic translational informatics. Informatics, there's an old joke out there that that informatics is actually everything. But in my work and my interest, it's what is the methodology to apply it to actually increase and improve the ability to do health research and biomedical big data research. So informatics is the umbrella, but when we talk about translational research, we talk about the combination of basic science research, no pointer, plus clinical and public health practice, applied in the usual context of patient care, so in the communities, in the academic medical centers, in the population health worlds, as to attempt to make and evaluate applied and dynamic impact on human health. There is a wealth of methodology and theory in informatics that has been established since the 50s, continues to evolve with relationship with computer science and information science and other social sciences, but we're, I think, in this place in late 2014, where the need to actually apply and test these methodologies is beginning to outweigh the ability to study them from the sidelines. So I'm a builder. I like to make things. And the thing is how you do translation. As Frost said, poetry is what gets lost in translation. I don't know what the owl means. Is that there is a very large ecosystem of where applied human health is beginning to evolve. This is kind of a classic view of the learning healthcare system, a data-driven learning healthcare system. Something that essentially is cyclical, that the design, the implementation, the evaluation, the adjustment should inform the ability to disseminate data and best practices to improve human health, and those very challenges should be able to come in and inform both the research and operational processes of academic health systems. Davis is part of the broader UC Davis Health, UC-wide health system. There's almost 13 million patients in this. 5 major medical centers, UCSF, San Diego, Berkeley, Davis, Irvine, and LA, and soon Riverside. There is, I think, quite a bit of movement to align and have a cyclical learning healthcare environment in the UC-wide system. The problem is that it's not as linear as, or even cyclical as one would hope. There's an enormous amount of pressure on actual doing effective work where the data generated and to be used in these environments originates, for the most part, from human beings. There's an enormous amount of pressure from the federal government to actually share these data, so funding agency, publications, collaborative research designs, community pressure. There is an increasing challenge to the complexity of privacy laws versus local policy law. HIPAA 2 and others has changed things a lot very recently, and it's always been a bit of a challenge. There's very limited systematic adoption of data persistence and how we manage and share data, how we maintain reference for it, how we can reproduce it, and what are the consequences of being able to evaluate it and rediscover it. We've learned that if we do this poorly, we can significantly affect community trust, which means that both communities of our patients, ourselves, as well as our interactions with our colleagues and peers. We are learning very quickly that privacy breaches have very significant professional, punitive, and personal risks. There is a recent statement by someone in one of the UC systems that there's an average of 3 to 4 information violations per week that do not ever hit the news because they are dealt with. But each of these, and when you see the ones that do hit the news, we're talking about, $750 million in terms of potential fines. Now, we're still trying to determine if that's true, but it is an ongoing threat. And fundamentally, data just doesn't share itself. It still needs to be helped along. Sometimes it shares itself a little bit through BitTorrent, but predominantly it is something that it needs process and methodology to advance. Now, there's pretty low expectations for this so far. So these are just a few highlights from the last few years of how these data that we are generating, we're trying to use in health research, is being effectively used. Nature data is shameful neglect. So we're compiling it, and it sits there, empty archives. These are empty archives of cures, not necessarily empty archives of data. Desperately seeking cures, next follow-up. I love this one. The rare sharing of data leads to results on Alzheimer's. And then we say that there's a data deluge, and we know there is a data deluge. It's more of a, deluge suggests it comes from above. I think as you jump into it, it's difficult to find one's way out. There are still troves of data that is inaccessible, that have barriers, both intentional and artificial, that are difficult to even imagine getting access to. And then there's the fact that the data itself is leading to inconsistent and sometimes not reliable research, which is causing significant retractions in the record. I subscribe to a thing called Retraction Watch, and there's about 2 a day now, based on publications that are, for whatever reason, are no longer considered reliable and have to be pulled back. And if you start pulling back enough of any of these publications, you will stop entire areas of research, depending on where things are. And then, there's the ongoing navel-gazing of what it means to deal with big data. And we all know a bit about that. This is just a recent review about that, if you have a sufficient amount of data, you can find anything you want in it and prove it, but it might actually not be true. So we have problems in our data management. We also have problems in biomedicine that are somewhat unique to biomedicine. We trail many other domains. Physics and astronomy have been fairly well effectively sharing data for some time. Energy, as I know, is a big thing here at Berkeley. One of my favorite quotes is that one problem we have is that we've always had a lot of data. We've always had probably more than have been generated of late, but it's always been in lots of different forms. So Herbert Simon in 1971 said a wealth of information creates a poverty of attention and the need to allocate that attention efficiently among the overabundance of information sources that might consume it. And this is a poverty of attention. We have difficulty in getting to the nut of it. My favorite personal comment from another university, not in the UC system, was, which just rocked me back on my heels, was that it must be so nice to be in biomedicine. All the data is so homogeneous. Which, if you think about it, I mean, it is just numbers and text, and that is homogeneous. But the range within that data exceeds, I think, most other domains, particularly in its messiness. So we know big data is kind of, where we're trying to head towards as like a concept or a philosophy. And just to define it briefly, it's hard to define. Wikipedia changes this pretty regularly. Data sets whose size is beyond the ability of commonly used tools to process in a tolerable time. It sounds very NP complete, but it's actually more of this kind of dawning awareness of there's a lot. How do we do something with that? Within biomedicine, I think the things that we are trying to really capture, standardize around are these so-called 3 Vs, is that we have an enormous dimensionality of data, and it's probably not always going to be portable. It's going to have to stay in place to some degree, particularly like whole genome sequencing. We don't want to necessarily, it makes no sense to move around a terabyte or two if a patient goes between clinics. Velocity. We are, capturing so much and moving so much around anyway that we don't really have any. There's there's been no time to reflect on that process. It's evolving very rapidly, particularly in small clinical care, intensive care units, imaging, genetic testing, you name it, and variability. There's an old XKCD cartoon which says we've got 10 standards, let's make a new one that subsumes all of them, and the next cartoon panel is like, now we have 11 standards. There is difficulty in standardizing access and approach to manage some of the biomedical data they're working with. But not for lack of trying. So this is as of last week. So Galperin publishes this every year. Has done this for about 10 years now. And so there's 1,552 biological databases available on the internet as of 2014. And this ranges from GenBank to OMIM to little teeny ones. 58 new databases last year. I didn't mention that something like 20 or 30 of them were taken offline. There's some updates to them. And this paper is just on these databases, 100 papers since last year. So there's plenty of resources. And this is, people spent a lot of effort on this. GenBank has got 181 billion base pairs, 178 million sequences. And the whole genome sequencing in GenBank has just in the last 5 years surpassed that base pairs, 805 billion and 196 million sequences. We don't lack for the intent, the ability to accumulate and provide this. And all these databases, I think, probably are somewhat under the philosophy of if we just make it, then we can start solving those problems. But I think it's interesting is that there's widely been bandied that sequencing is outpacing Moore's law. Actually, it turns out it isn't yet. Moore's law is still outpacing genetic sequencing, but only, I don't know, I think the genome stuff, HWGS stuff hasn't been plotted on there yet, but they are parallel. They have the same challenge. That is, I think, the take-home point. They're mostly parallel. So what this kind of means, and this is written on a cocktail napkin about 8-9 years ago, is that the data's increased and we have not increased. Back in the late 80s, when you're a clinician or you're trying to do research, you had a limited amount of clinical phenotype data that you could work with. What you could directly capture, what you could capture from some EHR systems, somewhat disorganized. And then as we've moved along, this data is spiked and is continuing to go up. And the amount of plausible potential related data is now, again, chasing Moore's law, whereas our cognitive capability is largely the same. And so making decisions upon this, in terms of at least what is reliable, is beginning to outpace us. So we are in a sort of a tricky spot because we need to figure out what is reliable in that cognitive capability section. And of course, we need computers to do that. Fundamentally, also, the cost of computing is cheaper, but this means the price of knowledge is actually getting more expensive. And we can throw a computer at these things all day long. But we are not actually seeing a yield in extracted knowledge yet that has any arc, really. And just mere availability isn't what it means, what it always seems, and quantity does not mean quality. So, I think we're beginning to see in biomedicine that unexpected obstacles is sort of our MO, and we need to work to overcome those. So, this is kind of in the context that things are changing too. So we used to have, and by used to, this is 15 years ago, probably at most, biomedical academic IT research culture was expert-driven. We had little labs, we had a server under the desk. We had tools. This kind of things like BLAST and other sequence tools that came about were the exceptions, but predominantly we had a lot of analytic packages, SAS, desktop, Excel. We had a pretty big distance from academics from industry. Intentionally so, at some point. We didn't want to bias things, but it was a long distance. We had laptops, we had servers. Occasionally we had clusters, and we had things usually on-premise, and at least in academic medicine, it's still true. We like to point where they are. We don't like them being in the cloud yet. We really should. And then there was limited few. This was essentially something that, in part because of the skill set, because you needed to have clinical expertise, biological expertise, and computer science expertise, it was relatively limited in terms of domain. Those were the good old days, right? But now it's changing. We have, not only does the government want this, but I think it's become clear that, data analytics, it needs to be very interdisciplinary. We need team-driven, complementary skill sets. I'm in many, many projects, and I'm usually one of several informaticists with other scientists, with statisticians, with computer scientists in these teams. We are now seeing that we are doing things in context. So we're realizing the efficiency of domains of focus and seeing, so we're all working on cardiovascular disease, sepsis, cancer registries, things like that. There's a lot of utility in building around those partnerships. We are seeing more and more, though it's still a little slow, public-private partnerships. Pharma recently, I think it was GlaxoSmithKline, made available all their data for research recently. They opened it up, not with any money. We have now we have applications and services that are available for like essentially a right click on a credit card. With software as a service, we have cloud approaches. We have deeply focused applications that do one thing, that do like profiling and various other preliminary support views in research. We have mobile as a daily thing. We have ubiquitous computing in terms of biosensors, environmental monitoring, public health. And we have now, I think, the ability that if not everyone, then there are crowds and there is approaching ability for a much broader range of people to engage in research, not only in the US, but elsewhere. And not only within the highly credentialed, but at any level. There is consumer science going on that is quite exciting. So we've tried to build these databases as to that slide, but I think to some degree we've had this history of building them much the same way. This isn't to say there aren't good data structures like EAVs and different types of abilities to define databases, but most databases, because we're humans, tend to emphasize reductionism. We kind of condense them down to what the thing they do best, and we push them forwards, and we distill our knowledge up, and we reassemble and we update them as necessary. And so this has been good. We've done this in the past for foundational building blocks, but it hasn't really provided us. It turns out it's more difficult to undistill and reintegrate than it is to build different things. So they're difficult in building some of these large collaborations. Particularly when you build something with a silo, you tend to put to some degree ownership and other legalities on that, and even here in the UC system, we've got 5 sites sharing data. We've got data warehouses. And we're all on the same page. It's still very hard to share those large warehouses. They don't necessarily lend themselves to systems thinking, but until we get through to the more a different form of how we build and train and evaluate these systems, we are going to continue to have silos because we often embed that knowledge. This is the only way we seem to know how to embed that knowledge and embed those analysis. This is the only way we can get to quality. So we're kind of in an awkward spot. That's the only way we know how to do it. Seems the only way forwards, but it isn't fantastic at bridging them. This is just a quick slide from a couple years ago when we did a study of just what we thought was a fairly straightforward thing. I was like, so you've got your data warehouses in a clinical environment. You've integrated them. Everything's linked under a master patient index. How do you provide that available to other people, we asked. And so this is, I think, about 40 sites around the country, big sites, UCSF, Harvard's, Pitt, thing like that. And this was out of the idea that if you had the ability to query these large clinical data warehouses, step, 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 profit would happen. Well, this is kind of just the approach, and this does not change from year to year. We're still approximately this. We are nailing things down by domain, and we're trying to figure those out, and then we're trying to integrate them across them. So the type of things we're getting access to now, and this is kind of the low end of data intensity: diagnostics, demographics, procedure labs orders, vitals, text notes, things like that. And this is what are included and what are not included, and that's another story. And then we said, well, how do you provide access to this? And this is on the right there. The general approach that we're trying to do is saying that even though there's not a lot of utility in de-identified use of these data, it's the only way to do it. So we're de-identifying everything, and we're basically sanitizing it down to its raw kernel, and then we're kind of offering it up for research. And we said, well, how's that going? And they said, well, we don't get a lot of traffic, actually, because people don't know how to use it. They don't know what's the point of getting to that. So we continue. We struggle ahead. We actually have a project in the UC system that I mentioned that's doing all these across all the 5 UCs, called UC Rex, which has got all 12 million patients in it that you can query on in real time in an open source database. But we are still having problems in what is the next step to that. So part of this is the identification that with these valuable data resources, we in biomedicine are still struggling in how to determine what is the value and what is the risk and how we make them available. And our go-to place is, well, you de-identify that, but that isn't actually great if you think about how patients actually exist in the real world and continue to add data and need to be engaged. So we also have challenges in trying to change that. So there's kind of 2 schools of thought in, well, 2 directions in maintaining patients with a goal of ultimately getting longitudinal data from them or with them. And one is just to further de-identify them, because we all know you can re-identify anything with a Netflix account and your zip code and your voting precinct. So how do you effectively do that? Well, there are methods. We can continue to apply these. We do. But the further we get into de-identification, the more difficult it is to actually see what is reproducibility of the data, continuity of the patients, and where patients' communities actually engage in their own health. So we're beginning to, again, pre-sanitize ourselves away from that. So it reduces specificity and utility. Now, the other option is to try to make very direct connections, personalized connections with patients, and gain their authority and their support. That's with citizen science and things that they call it dynamic consent, and things come along. This presently, though, is difficult because these population sizes are much smaller. You actually have to spend the time engaging with people. You actually have to determine what is legal and what jurisdiction. And it turns out state by state is very different, as is even city by city, depending on certain things. And then it has both the boon and the challenge that you wind up actually changing the way that this biomedical science is done, because these patients, in many cases, become participants or even help lead the work. And there's an institute called PCORI, Patient-Centered Outcomes Research Institute, which is $700 million a year right now, 1% of Medicare, which is dedicated to this last statement of how you actually have participatory engagement in patient outcomes research. So it's a real, extremely well-funded thing that is as yet unsolved. But despite these things, we are seeing some pretty great kind of cool step forwards. We know, there's massive enthusiasm. We know the microbiome is, a few years ago was laughed at, and now it is. There's startup companies in the Bay Area that you can do it. Ubiome is one. We know that the ability for secondary use of data acquired through, health data acquired with things like Google is predicting influenza before it happens, before it's publicly noticed. So we know there's a lot that is really. We're still very enthused, though I wish someone would come up with a better term for big data. So we're still enthused. So some of the reasons we're enthused is that it turns out there are themes that are improving our ability to build and systemize around this. As boring as it may sound to some, not me, reproducibility and persistency and transparency of data is absolutely the foundation for what we're trying to do here. Something approaching 40% of NIH clinical trials do not get sufficient patients enrolled in research and are cut out. There is a unknown amount, but a very large amount. I recently saw this, I don't remember off the top of my head. Significant percentage of these trials that are published, it is impossible to get the data for secondary use. It is just no longer persistent. It is link rot, as they say. Nature right now is actually piloting a process by which the data submitted from a publication will be submitted in real time with the analytic methods, so the reviewers can actually run the analysis themselves at Nature on the data to see that it's really there. And then they would house the data on behalf of the contributors. This has got a couple different perspectives on it. One, researchers aren't that sure they like that. On the other hand, they don't have a great plan, backup plan in many cases, and institutions are not very good at maintaining these at all. Systems thinking, this is again from design. We are knowing these lessons. We're seeing some work that is trying to really focus on how do you make fault-tolerant systems that actually that can tolerate ambiguity, yet still are advancing the science. Implementation as a science, there's a whole journal on it, and it's about you can't just install complex systems into complex social environments and expect them to work. There's been famous cases from over a decade of installing EHRs in places like Cedars-Sinai, $60 million system where it was so badly implemented that the doctors revolted and they pulled it out about 2 months later because they felt that the system itself was causing death. We're seeing obvious pathways and linkage to actual real computing resources and storage resources and the study of e-science, which I know Berkeley's got a great new center on. We're seeing how we actually do evaluate and test what it means to change the connection from, as Helen Nissenbaum once said, from patients who are always considered as dreams or dots to actually trusted engagements and things that actually have connection and engagement. And we're seeing that patients are not moving to be more than just patients, but they're also data generators and their participants. So we're seeing things that are, these are very literally happening constantly, and there's tons of federal funding behind it, but I think we're still in the stormy years of it. So one of my icons is Mitch Kapoor, who states the design of systems turns the kind of politics that can take place in them, and designing a system is itself a political act. And I think that that is very much where we are in trying to implement realistic and usable information systems in our age now. We actually have to be risky about it and push things out that may not be the most de-identified or industry level work, because we know we're going to have to refine them and evolve them. Those are risky challenges. So learning healthcare system, as it defined, is that we're at a place where it's possible to have a system that can do this. It's been possible for a while, but the meaningful use criteria from ONC, the healthcare reform, and then this intense focus on patients is really, by PCORI and NIH and NSF, is really making this a perfect storm to support and advance this. But what, of course, I would like to see is a learning healthcare research system. And these are the things that we've been discussing that can be, that need to be supported in that. In addition to making this connection of meaningful of engagement, we need to be able to capture, represent, and manage high-throughput, multidimensional phenotypic data. And this includes phenotypic data from patients on their Fitbits and their Withing scales, and who are sniffing the ozone layers or the pollution out there in the world. We need to provide reproducibility of hypothesis discovery in systems that can put the researchers at the whatever proxy it is for the Google desktop of discovery. We need to lower the barriers to connecting those two things. We need to have rapid clinical study design. A lot of our clinical studies take a very long time to get started, almost entirely based on enumeration and, of course, protection. And we need to recognize how to adjust them if they are not recruiting or if they're not actually doing things. We need to support multi-scale computational analytics, and this means we need much greater partnerships with the machine learning people, with the deep data analytics people, with the biostatisticians. One thing we've done a lot of is that we will design a project by one group, we'll hand that off to some ETL people to extract data, then we'll hand it off to a biostatistician who will then hand it back to the design group. Well, we need to actually realize where the methodologies are that actually can encompass those roles, and some of them are the ones that we train our investigators in from the very beginning, and our MDs. We need to ensure that we have that there's multiple levels of engagement by how researchers adopt these. Not everyone is trying to do hypothesis discovery, and that frameworks for how you have team science are very important to consider. One thing I love about CITRIS is the last two words is the interests of society. We need to understand that our team science is evolving itself, and it needs to be supported as such, and it is not something you can print out in the last minute. And we need to build private research and private industry across this. I think we're in that academic system. We recognize we're great at innovation, but we're not so good at development, and we're very not good at dissemination. So we need to actually leverage these things more effectively. So this is a kind of a classic slide of the 4 Ps of precision medicine, and these are kind of the axes that we're building around some of the capabilities. So predictive analytics and preventive. So prediction to prevent leads to personalized design and participation. And I think it's pretty straightforward. And I think you will see that you begin to see that in like diabetes, and you begin to see that in even like quantified self and things like that. You can see some of that engagement there. What we try to do more in the academic sense is that we want to increase the ability to have patients provide biosamples, particularly those with parents, children, or family with rare disease or any kind of disease, or even the healthy. We want to actually begin to annotate. There's unfortunately a pretty negative case from Texas last week about how they were blaming the clinical record for not querying the patient whether or not they had come in from Uganda. And that wasn't exactly the clinical record's job. But we do need to automate annotation that can really build on these descriptive health outcomes and phenotypes and family history data in a much more comprehensive way than we presently have. We need to lower barriers across these data, particularly genome data and epidemiological data. These are still they're running very fast in 2 parallel threads and don't interact very often. We need to ensure that there's appropriate and effective privacy relationships for the contributors of these patients, because we want partnership on that. And we need to really expedite how we translate these. We're still in this world where the standard drug discovery pipeline is about 11 years. There is different scales of dissemination that we can definitely address. We need to determine how we change from things being a patient-centric environment to more of a participant-centric environment. Patients just are generally in their own health, and we will always have that. And the patient health portals, which were really exciting 5 years ago, have not changed much. And the data was clearly owned by a health organization. We want to move to something where the individual is a participant in their health. There's a 2-directional path. This is most relevant with this whole direct-to-consumer testing and the whole Fitbit kind of thing, but there's a million other things that needs to be able to capture. We want to capture the kind of the civic opportunity for volunteers in a way that it is actually addressing not only those who are sick, but the youth who have no interest in this sort of thing. We direct-to-consumer genetic testing. We know it's kind of working. It isn't really. It's complicated. 23andMe is still suffering under proposing knowledge that perhaps was a bit of a reach. But at the same time, we are learning things from our citizen populations, and we need to be able to understand and capture that. Environmental outbreaks, anything that is happening in the community now, we need to be able to have control, have ability to engage on it, and we need to determine exactly, whether and how and when data that can be simultaneously owned by an individual or borrowed by a company or collaboratively owned, managed, can be effectively used. There's a initiative out called Free the Data, which is simply trying to bring back all the BRCA outcome data from Myriad, which was embargoed, and they were trying to use to resell the breast cancer tests commercially. And now every patient who's ever had a BRCA test has been contributing the data in for public use and public good, so that we can, frankly, continue to do research versus the company owning the outcome of those tests. So that kind of work is necessary. We need to determine architectural structures for actually managing this very large types of distillate data. So this is just one paper a couple years ago I wrote, where you can, there's a pyramid. There's a kind of a Maslow's hierarchy of needs, if you wish, that gets up to the interpretation. And there's different levels of how we need to architecturally design, do systems design to support the effective use and utility of this, as opposed to some of the things that we might already be doing. And at the bottom, we're getting massive amounts of reads on the next-gen whole genome sequencing work, but we really are mostly working on the diagnostic interpretations, and we do a lot of compression across these things, and we can recognize the value of where and how these can be translated, and map and model them out as necessary. This is kind of a few slides on that. It's relatively straightforward things. We need to separate molecular observations from clinical interpretations, support compression between them, we'll make linkages back to the provenance of the laboratory tests so we can reproduce those items, compact and represent compact versions of clinically actionable subsets. Most importantly, probably here, is that we, as much as we want to manage machine-readable work, we need to evaluate and expand human-readable and human-interpretable information. We want to essentially anticipate building systems that are not, will not precalcify themselves into not being able to expand to the next level of either human collaboration or molecular evaluation. And we want to, continue to support both functionally clinical care, which is the learning healthcare environment, but we also support discovery science. There needs to be ongoing abilities to provide the evolution upon these massive resources and warehouses. So I love this slide. This is all still mostly a framework. There is much that is only kind of evidencing itself in rare areas, but it is definitely evolving, that we have a lot of distilling capabilities to be more actionable and more engaged to actually use these data and stop having almost self-generated barriers on it. A couple of good ones. 2012, this was great. If you haven't seen this, watch the Nova special. They did an N01 trial with a patient and cured the patient. The patient rare genetic disease, sequenced them, found the alleles, made a medication for it, cured the patient. So Nova went back in and tried to do the same thing and failed, and it was not good. It was, not surprising that they failed, but it was sad. I mean, it was very personal. This family was very committed. They did not find a solution to this. But there's expansions of that, and what you partially need for that is a lot more data. And so there's companies like Sage Bionetworks in Seattle, Genomera here's in the Bay Area, same as Patients Like Me and 23andMe. They're all beginning to have this balance between what is, the provision of data from larger crowd views that would aid in this not being N of ones and do lead to these rapid personalized medicine approaches. I mean, it's fantastic to have any successes, but it is, and it's not surprising to not have regular successes. The other big thing that is going to happen is that there is these large advocacy-driven science groups. So I'm part of a group called Genetic Alliance. It's over 2,400 rare disease advocacy groups. They are collaboratively, there's the groups that never get NIH funding because NIH tends to choose certain things and they're too small, but they're basically amplifying. They're going to Congress. They passed the GINA Act, the Genetic Non-Disclosure Act, collectively. There's activities coming from the participants' quarters that probably wasn't possible before, I don't know, 5 or 6 years ago, when the internet became such socially enabled. So that is happening, and then things like 23andMe and quantified self. 23andMe has a thing called 23andWe. It's a research arm that basically engages on aggregate data and works with industry. They do things like that. And quantified self, if you haven't already heard of it, it's had a bit of a identity crisis in that it never thought it was going to be about research, but it's rapidly shifting into that. There's a lot of quantified self is something that there's a couple of charters here in the Bay Area. It's all about, I can't find my solution to my health problem, so here's what I've tried upon myself, here's what I learned, and here's what I did, and here's how I learned it. We're beginning to see that kind of be more available in much broader settings. There's a fantastic report by Robert Wood Johnson down at UCSD that did this about a year ago. Probably one of the other better ones that really sums it up quickly. So Sergey Brin has a, I think it was his, I want to say, cousin with Parkinson's disease, and decided to test a mutation and had heard about the research and got very intrigued in this, and had basically looked at mutation in Gaucher's disease, which this was the classic trial on the left, very large scale, 16 centers, 6 years, 5,500 Parkinson's patients. Did the analysis, did the draft, 64 co-authors subject to NEGM, noted that there was outcomes of 5.4 times more likely. Sergey Brin built a bunch of surveys, recruited 10,000 patients with Parkinson's, got the DNAs, the personal community DNA analyzed, filled out surveys, ran a database query, 20 minutes got back, returned that is 5 times more likely than Parkinson's, last time 8 months. So I think we're beginning to see this possibility when you kind of bridge these challenges and these barriers, and you begin to see the leverage that can be brought together with directed collaboration. So last couple of things. So these are the kind of things that we, again, to hammer the point, I guess, is that for translational research environments, and I am clearly have Stockholm Syndrome, that's all I think about. So we need ongoing testing and evaluation of new models of collaborative science, not just projects, but models of science. Like, how do you have collaborations? What is a citizen science project? What is a collaborative project where credit and value and outcome is shared differently? And also data and resource sharing. There's secondary use of patient data. There's a couple of steps, but after which it becomes unclear on where value is to the patient, to the people that have contributed it, and it's unclear whether or not that's important. But we need to be able to test this. We don't know, and we need to be able to test it fairly rigorously, ultimately. We need cyclical positive benefit, because the learning healthcare systems need to have more going for them. That research is an interesting thing. Research in academic medical centers does not pay the bills at all. I think our research budget at Davis is probably, almost $2.7 billion, and our IT budget is, clinical operations budget is like $2.7 billion or something like that. For our healthcare system, and research is probably $300 million. It's a pittance. So we need to have a different benefit for how that can be improved within those environments that is unique to those worlds. And we need fundamentally trustworthy approaches to supporting regulatory ethics, data provenance policy, both within and across informatics systems, and trustworthy meaning that we need successes in these things. So George Church, who is on, if there's a spectrum of data sharers, he is like redlined towards the sharing, and he's a fantastic advocate with Personal Genome Project and other things. What we've learned in terms of how we build our systems is that it's not a good idea to place a higher importance on the use of standards than it is to actually place on the ability to actually adopt those standards. So loose standards that can be improved is more effective. And this comes from projects like CA-BIG, which is the $300 million NCI project that failed, to I2B2 and things like that, REDCap and other things. So making the adoption of these standards needs to be easier than harder. And this is, I think, our key thing, is that we need to focus on efforts that facilitate data sharing where the problems themselves cannot be solved by isolated groups. They need collaboration. They need larger groups. That's where you build larger scaled systems. Recognizing that single monolithic large systems probably are not the future, that an approach that software and other systems that support this should be essentially solve one problem at a time. Nimble, agile software methods try to degenerate and establish specific impact in months, and if not months, then very regular short periods of time. Chart realistic incentives to use, like waiting, if we will build it, they will come, is never worked. And we know that just merely either financial incentives or punitive incentives to using these methods and systems doesn't work very well either. And this is back to the public-private partnerships. We want to actually participate with organizations that are willing to develop and expand and utilize these systems themselves, and looking for that kind of adoption. And I think I'm not sure if that clock is right. Is that 10 minutes fast? I don't know. No, I guess not. This clock's right. So this is kind of the pathway that we see in terms of true translational informatics. And traditionally, it is when data-focused, application silos, engineering approach, existing technologies, and there's a transition from data generation to application of knowledge. What we need to be able to see is a bidirectional path between data generation, application of knowledge, that actually focuses on the context of the information that is being connected, how you integrate that, how it's interactive, how it's engaging, and what is the innovation component that comes as part of the system. And we are seeing this in many areas, but still needs to be scoped. Final slide for the e-science. And this is kind of just recognizing a history of how some of these systems are being taken up, things like BLAST and other kind of big computational biology methods. So there's isolated adoption. This is researchers use tools within a particular problem area. They use some reuse of tools, Linux, data methods from the discipline. Generation 2, reuse. So the reuse increased pools of tools, data, and methods. Research objects became built. Communities were built around that. And then Generation 3, suddenly it jumps over the bump, and there's global reuse of tools. There's data and methods across all the disciplines. There's a long tail that continues to happen after these first. After this adoption curve. And we see this with everything in the social media world, and everything from Facebook to Twitter to iPhones. There's a great paper here, the best titled Machines, Methods, and Music on the Evolution of E-Research, well worth looking at. So this is Pragmatic Translational Informatics, kind of approach that we're trying to champion here and elsewhere. Of course, make it as ethical as possible. We know that there's much risk within changing the ways that patients engage and working with pharma and competitive intelligence and things like that. But that's it. David, thank you very much.
Thank you, Nick. We're getting close to time, so we'll have time for one question or so. Wonderful presentation to take us through this large, exceedingly intriguing space. One thing we would like to mention for those of you who are here who are interested in this, CITRIS will be championing this area, moving into healthcare big data in a number of ways, but we'd like to just bring to your acknowledgement right now that in the near future we will be doing a seed grant program to help jumpstart programs here in research in this area, particularly cross-campus, multidisciplinary approaches to address some of the wonderful issues that Nick has raised for us. We have time for just one or two quick questions before we hit our time, and I believe Nick is here for a short period of time afterwards. And we have a microphone if you have a question.
Thank you. Is the model of the standalone one-drug clinical trial obsolete?
I wouldn't say it's obsolete, but it's, I think, being the big shift in the one-drug clinical trial is being shifted to more this pragmatic clinical trials. And pragmatic clinical trials means how do you test something where you are not over-specifying the population of test as much, and for example, the clinical study staff are not the expert translational research nurse, they're the community nurses. It's moving from, I think, it's trying to say that the generalizability of that, instead of doing it in those stages, we now do a broader, somewhat shallower approach, and then over-specify after the fact. So there's like about 6 pragmatic clinical trials going on in the country right now, totaling, I think, about 6 million patients, so it's big. But they're doing things like lower back pain radiology as a response after diagnosis, from data perspective. The one-drug clinical trials I don't think are ever going to go away for human subjects and human protection, but I think we're shifting in that has been one of the slowest steps on the pipeline, historically over time. I think we're trying to see how do you run, how do you stagger that as much as you can, so you both do large validation at the same time of getting like deep utility. But no, I don't think it's going away.
People usually refer to Fitbit, as you did, as an example of these wearable biosensors. I'm wondering if you think with the Apple Watch and Samsung and Google, these big $100 billion companies coming into this space, whether they will be somehow different. They'll really change the environment than what a small Fitbit company could do.
Are you asking about will they change just the potential contribution of Fitbit? Yes, probably. But I think the bigger question is that none of these data sources, as I understand it, have any real validation behind them. I mean, a step is not a step, it's not a step. I mean, even a blood pressure is not a blood pressure, not a blood pressure yet. It may get there. And then if you were to try to actually take them into context of clinical environments, until you have something that systematically provides value, reproducible, provenance-based data acquisition, then most clinicians are unwilling to use that as like a viable, diagnostic. Well, I mean, that's not how it works. Now, we're trying to change that, and I think we're trying to validate certain frameworks. There's a framework out of UCSF called OpenM Health that is doing a semantic translation layer there. But I don't know. I mean, one thing that galled me a while ago is when Nike Fuel Band came out, they redefined calories as fuel points. And I was like, well, that's great, but that means it's not about, it's about something different. I think we'll see. I mean, the cost point of these Fitbits is standing relatively the same, but I think when all these new devices comes out, it's going to drop very quickly. And people who are just kind of curious will be picking them up. Yeah, good question. I don't know about the economics. It's not.
I have one quick question, but maybe the answer is going to be long. We can take it offline. I was intrigued by the comparison of the 2 studies, one done in 6 years, the other done in 8 months. And I wonder what the quick study leaves on the table. For example, provenance, peer review, any acceptance by the scientific community. Can you comment on that?
Yeah, I think the second study definitely does not have the acceptance of the scientific community. It was peer reviewed by the participants, peer participant reviewed, whereas the primary study was classic. But I think those things could possibly be adjusted over time. There's other ways to have peer review that could involve academics in different forms there. That first study, I wouldn't want to poke holes at it, not knowing a great deal of data on it, but 6 years of accumulating data it may be difficult to locate that, historically. Whereas Sergey Brin's study, that was all right there. They had that data persistently, transparently, so if it was a question of reproducibility, they could do it. So I think there's something to be said about, the latest, sounds bad, the latest and greatest technologies will provide us a better ability to be compliant with some of these new needs for reproducibility, because there hasn't historically been institutional support of these data sets, and there's not really been easy capability to coordinate across 16 centers. We still struggle to coordinate across 5 UC centers, and we're all really good friends, in this world. So I think, it's probably a very reliable study. I don't know anything about its reliability, but I suspect they did not design it to be a data reproducibility study. They designed it to be something that was specifically on Parkinson's, and they probably didn't involve a lot of systems, and it would be difficult to extend it without going back to the original data sources, the patients themselves. So I think there's a lot of gaps and changes there. I can tell you another story about lack of data persistence at some point. That the quick outcome of it is that there was a university very quickly that actually had made a statement about a very public thing, and they had caused this public thing to be withdrawn from the world, and then this university in question was audited for their original data, and they had lost it. And so the whole scientific credentials, credibility of justifying the poorness of this thing was shut out of the water by them not actually being able to back it up by how they managed to deal with their data. And so the thing is now back, so it's just one of those things. Yeah. So, we have an obligation to frankly, to design the environments to support those things, because it's kind of a rookie move, really. So, yeah.
Nick, thank you very much, and if you folks would join me in thanking Nick for bringing us through and seeing this whole new area in a wonderful light, and where we are in the thick of it here, not only at CITRIS, but within the entire UC system. Please join me in thanking Nick Anderson.
Thank you, David.